Good afternoon. Hello, everyone. A very warm welcome to all of you joining us today. My name is Gisela Hansen, and I am the head of International Relations and Advocacy at Dianova International. It is a true pleasure to open this webinar organized by Dianova and the World Federation Against Drugs in this amazing webinar called Healing Trauma in Substance Use, an Intersectional Approach to Care and Rights. First, I would like to thank you all of you for being here and for your commitment to this important discussion. We are truly delighted to have nearly 200 registered participants, which is amazing. Thank you very much, all of you from across regions and organizations. Your presence reflects the shared dedication to understanding trauma and substance use through a compassionate and evidence-based lens. So before we begin, just a very few practical details. This session is being recorded and the recording will be shared afterward. And also simultaneous interpretation is available in English and Spanish. So you can click the interpretation icon on Zoom to select your preferred language. And afterward, we will have a Q&A session at the end, but you're welcome to write your questions at any time in the Q&A box. You will find it in the bottom below. And today's webinar is about exploring trauma and substance use through an intersectional and rights-based perspective, and about recognizing that healing requires collaboration across sectors, from prevention to treatment and harm reduction, with human rights, dignity, and science at the center. So I want to express my very big thank to all of our amazing speakers today, the partner organization and the World Federation Against Drugs, for their shared commitment and excellent collaboration in making this event possible. So it's my pleasure to head over to my co-moderator and colleague, Cressida DeWitt from the World Federation Against Drugs. Cressida, over to you.
Thank you so much for your kind introduction. And on behalf of WFAD, we also want to give a warm welcome to everyone joining us here today, the speakers, as well as everyone participating. And as Gisela said, the topic we're exploring today couldn't be more important because, as many of you know, trauma is a key denominator in substance use that is often left unaddressed, misunderstood, or overlooked in prevention and treatment services. And when that happens, care can fall short and the impact on people's lives can be profound. And so I'm thrilled today that we are joined by such a diverse panel of speakers bringing together scientific expertise, clinical practice, community perspectives, and lived experiences from around the world. And together they'll help us move from understanding trauma to taking action and building systems of care that are compassionate and evidence-based and truly inclusive. And it's my very honor to introduce our first speaker, Angela May. Angela is the chief of the Research and Trend Analysis branch of the United Nations Office on Drugs and Crime, and she oversees global, regional, and national research in the areas of drugs and crime. And just for everyone here, she will give her presentation. After that, we have a short Q&A just for her presentation, so feel free to already post your questions during her presentation in the Q&A box. So Angela, the floor is yours. Thank you for joining.
Thank you. And thank you actually for inviting me to share the findings of our global research. So I'll right away share the screen. Okay, I hope you see it. Perfect. So I hope that many of you are familiar with the World Drug Report. If you're not familiar, it's our fault because it means that we are not able to reach the people that we hope to reach with this evidence. So I will try to, briefly tell you what we have as in terms of global findings in terms of drug use and its consequences, and also how global responses where we are with the global responses, both related to criminal justice and health. So let me first start this, since I hope that communities like yours can make use of the World Drug Report, and really is a rich source. And here I just want to tell you that if you go to the UNODC website and the UN World Drug Report, there is a wealth of information. And I'll start from the last one on the right, that is drug patterns and trends, that is an online platform where you can find hundreds of graphs, maps on everything that relates to drugs. And you can search by drug, by topic, by demand, by supply. And then looking from the left, then we also have in World Drug Report usually topics that we analyze analytically. And this year, and I'll talk to you about it, we had a chapter on the impact of drug use. But then we package all of this findings information every year on what we say the key findings, where you can find what I would say stories lines that look at the latest findings, but also some of these topical issues that are important. But the special point of interest is actually what we call the minister messages, so that, to address more high-level policymakers on key messages. So that's just to tell you. And then there is plenty of maps, data that you can access. So that's for you also to present, to make presentation, to make the points, to advocate. You can find a lot of material there. And so let me tell you what we had this year in terms of drug use. And you see here that, on the bar, on the yellow bars is the number of people who use drugs. And you see that it keeps increasing. And the point is the prevalence. So in terms of global number, we had in the last 10 years about almost 30% of increase in terms of number. But this also relates to the fact that we also have more people globally. So what is important is to look at the prevalence, so the percentage of people who use drugs, and you see that has been an increase of about 15%. But again, as you well know, it's not just the people who use drugs that is important for policymaking, but those that are really trapped into what we call drug use disorders. And you see that even there we had an increase about 13%. And in the map, there are the different colors related to the different type of drugs. So, for example, light blue is ecstasy, dark blue amphetamines, green cocaine, and red opioids. And here, without going through the details, the number of people, so the larger the circle is, the more people it is. But it's just to see that some regions are more affected in terms of number of users, but also every region in a way have different combination of drugs that affect what we call the market. Now, what is the issue of drug use? And it's not only drug use, it's also supply. What do we call drug markets? To give you just an overview, I don't have the time to go through the many findings that you can find in the World Drug Report, but I think I wanted to highlight that there are different issues also relating to drug use. One is the non-medical use. But extend, then we have a big trafficking on what we call pharmaceuticals. Example, tramadol, methadone, codeine, pregabalin. And for example, tramadol is the big drug issue in West Africa. So each region, and particularly low-income countries, are affected particularly by this non-medical use of these substances. Pregabalin, for example, is a substance that we hear from many countries, particularly Middle East, that is really increasing. But then there is, we can say, the traditional drugs. And there we have an incredible, continuously expanding cocaine market globally, and also reaching new destination market. I mean, in Europe, we all know how much this is continues to fuel, and is a more of the supply is increasing, the demand increasing, and one call each other. And so we are at the point where there is this kind of vicious circle that they continue to increase the global markets of cocaine. The heroin actually is down because of the large change in Afghanistan. And the Taliban ban on opium has really drastically reduced the global supply of heroin. Methamphetamine continued to expand and also reaching different markets. The amphetamine, where the biggest market of amphetamine is Captagon in the Middle East. And here, there are some issues since the regime in Syria changed, since Syria has been the major producer of Captagon, but we're still watching what is happening. But then, as you know, the new psychoactive substances, so those that come to the market that are not controlled internationally, but they can, that they harm people. And here, what to highlight is particularly this, the nitazens that are, everybody knows about fentanyl, and now fentanyl has impacted in North America. But actually, what it looks like is the biggest threat now globally, and also outside of North America, even in North America is nitazene. So they're even more potent, opioids that are even more potent than fentanyl. And so something really that is important to watch. But then what is also the biggest challenge that is seen and that everybody see, every country, is the increasing combination. So it has becoming more and more difficult to talk about single substances because, forensic analysis and it's clear that more and more in the market, there are combinations, and more drug users, people who use drugs, do not know what they use. They think they're buying cocaine, they are thinking they're buying maybe heroin or something, and there is a lot of cut that can become very harmful. Now, in terms of drug use and harm, so what is the biggest harm of drug use, again, globally? And here, we can see at the 14 million of people who inject drugs, and as we know, the evidence is clear, injecting drug use is among the most harmful pattern of drug use. But also this 7 million live with hepatitis C. And here you see the number, 1.7 with HIV and 1.5 living with both. But it's interesting to see, if you see the right side are deaths globally, the number of deaths relating to drug use. And you see, and these deaths are categorized as direct deaths, that is mainly overdoses, and indirect deaths. And here you see the total. You see what is the biggest portion of the deaths globally is actually included in indirect. The green that you see is relating to particularly hepatitis C. And the violet is, again, indirect deaths related to HIV. So, and then the dark green are direct opioid use disorders, so basically overdoses for opioids. So, mainly, from here, what is the substance that kills more people globally? Clearly still opioids. But what is that make people mostly died globally is still relating to this impact of drug use that is preventable. All of these deaths are preventable. Overdoses, as we know, are preventable. But also, infection diseases related to drug use are preventable. But when we ask, what is the drug that is most harmful? And there is not really one discussion. If you see, direct deaths, starting from the right, you see here is the sheer, in our data collection every year, we ask countries, and each country to tell us what is the drug that make people died for direct deaths. Then we ask, what is the drug that bring most people in treatment? And then what is the drug that brings most of people have drug use disorders? So you see that for the deaths, clearly the blue, opioids, the same as the data that I just showed you. But when we ask about people in treatment and people with drug use disorders, you see the cannabis, that is like the green, blue, and the opioids. Actually, like 41% of countries, they say that most of the people that go to treatment are relating to cannabis. And 34% of countries say opioids. So here is just to say that what drugs is really most harmful has a different lens that can respond to this question. Now, the impact that we have done an analysis, and really you find in the Water Report a chapter with full of scientific evidence from scientific literature, data, global data, etc. And here we have really documented the impact of drug use. And basically we show how, the impact depends. There is not a linear impact between drug use and impact. Because first of all, it depends on the type of drug. Some drugs are more, produce a higher impact than others. The way of, we know that injection, for example, is more, has a higher impact. But what is important to see here is that there are what we call modifiers. There are issues, that can exacerbate the impact of drug use or can mitigate it. One is individual factors, sex, age, race, ethnicity, social and economic status. So we know, for example, that the majority of people use drugs are men, but again, now we see with the scientific research that actually women, for example, move faster once they start using drugs. So there are definitely sex-related differences. But also age. We know that adolescents have the drug use among adolescents has a much higher impact because the brain is still developing. So this, in a way, if you want, individually can be, of course, I mean, sex and age are given, but and race, but maybe social economic could be changed, but they are in a way static. What is important to notice is that the contextual factors also have a great impact on impact. And so the policy environment, the availability of the services, the culture, the stigma, there's clearly, the higher the stigma, the higher is the impact of drug use. And so again, I don't have the time to go through all of this, but you will find in the report, all of this analyzed, discussed, and substantiated with research. But we also have an analysis on, how all of this, again, you saw a line, but it's not a line. Once there are certain issues with the impact also can influence drug use itself. So it's a complexity that you will see in relation to thinking about drug use, the impact and all the modifiers. But also what you will see in the report to also to see who bears the impact. Clearly, we know people who use drugs, but also, is also the family, the community. And again, you can find in the report all of this description on how those that live around people who use drugs are also impacted. Now, I don't have the time because I think I'm also over my 10 minutes, but I wanted just to give you a flavor on globally, what is the response? So we went through the impact. And here we put together the data from it's a global perspective to say how many people go for the criminal justice system. And here you see that the first layer is arrest, the second is prosecution, and the third is conviction. And here are estimated global numbers. And we divided by people that go through the criminal justice system, those with offenses that are related to drug possession and use, the light green, and the red, those relating to offenses, drug trafficking. And you see that basically the criminal justice system remains very, if you want, punitive globally. With the majority of the people going through this criminal justice system related to drug use and possession. So that is from the criminal justice system and from the, if you want, the drug trafficking side, maybe more resources should be given to actually capture the traffickers and to give health responses to people who use drugs. But we see that in some countries, particularly low-income countries, often do not have a health response. And so often, putting people who use drugs in prison is unfortunately the one. I just came back last week, I was in Syria. And so they were saying how by law, just drug use bring people to prison. But they don't have an alternative. So, and here is just to say, and I don't have the time to go through, but just to give you an appetite so that if you're interested in this, you can go and look at the report. And here is, we try to see how many countries criminalize the different behaviors relating to drugs, from cultivation, diversion of precaution, production, etc. So now maybe you just wanted to see the personal use. Not all countries criminalize drug use, but many do, 41%. Of countries in the world criminalize drug use. And here on the right is just to see by region that basically Africa is the most punitive region in terms of criminalization of drug use. So in contrast to this picture, when we look at the health perspective globally, here is the percentage of people who are in treatment, those with drug use disorder that are in treatment. And, globally, just 1 out of 8 persons with drug use disorder is actually in treatment globally. And here you see by region, and clearly Europe and by sex. You see that the highest percentage is for male in Europe. Almost 30% of them are in treatment. But the percentage the difference, so you see here the difference between the light pink and the red, that is male, female, and male. And so you see the striking difference. And globally, if about one out of 7 men with drug use disorder in treatment, 1 out of 18 female are in treatment. So clearly there is a disproportionate gap of drug treatment for women, but also there is a huge treatment gap globally, and in some regions more than in others. And just to finish, I wanted to give you an idea on kind of the other services that are treatment relating, for example, to this is the percentage of countries. So it's not what I showed you before, it was people. Now here we are back to look at the percentage of countries that, they say they have, according to the availability of opioid agonist maintenance therapy, the first on the left. The second is, again, the share of countries reporting the accessibility. And you see that about 76% of countries say they have available, but then when in terms of accessibility, this percentage is much lower in terms of the number of countries. And then on the right, you see the share of reporting countries according to accessibility of naloxone. As we know, the accessibility of naloxone really helped to prevent overdoses. And again, you see the majority of the countries don't even reply. And so very few talk about the availability, only 5% they say they have without a prescription. And if you see on the right is the share of the reporting countries according to the coverage of needle and syringe programs. And again, you see how a very small percentage of countries report their availability. So with that, I leave it here.
Thank you so much, Angela. Thank you for your remarks and for setting such a strong global and very conceptual framework for today's discussion. We are also deeply grateful for your generosity and for your time and for your continued closeness and collaboration with civil society, one of the temples that you are here today with a very packed agenda, so we really appreciate. As Angela, we have to leave us shortly. We will take a few minutes now for 1 or 2 quick questions before she departs. So you can also share your thoughts in the Q&A box here in the chat as well. We have a few questions for you, Angela, maybe not easy one, but we have a few minutes. The first one is, how do you see trauma-informed approaches being better integrated into national drug policies and data system in the coming years?
Yeah, easy question.
Yeah, it's a tough one.
I mean, it depends what you mean by trauma-informed approaches. Because we try, to think about when we do our data collection, etc., we do try to bring this perspective. But clearly, there are certain things that you cannot express with numbers. Oh. And we're very eager to, collect also qualitative information that can help us. One of the things that I can just comment is to say, what we see is that even if the evidence is clear between, because I saw this question also on depression, on the link between drug use and mental health, the responses is still very, the linkage in the responses is very poor, still.
Thank you so much, Angela, for your remarks and for all your answers. It was a very tough question. We had a few one, but we are running out of time. So once again, thank you for your insights and your dedication to evidence-based human approach in drug policy. So thank you. Thank you very much.
Thank you. Thank you. And thank you to you for all of the work that you do to make it.
Thank you. Have a nice day. Thank you. Now we will move from the global context to a regional perspective that turns science into action. So it is my pleasure to introduce Rocío Suárez Ordóñez from SAFI, who will present Trauma, Myth, and Addiction, Turning Science into Action. Rocío is a clinical psychologist and international consultant specializing in trauma and substance use disorder, a former research fellow at the University of North Carolina, and she has collaborated with CICAT OEA and other international organizations She currently leads SAFI, the Trauma and Study Initiative, and is recognized for her ability to translate cognitive science into practical, accessible strategies for prevention and treatment. Rocío, querida, the floor is yours.
Thank you very much. Let me see. Tell me, please, if you see my screen.
Not yet.
No, not yet. No worries. No worries. You will see it shortly. Now?
Yeah.
Yes. Okay. So just recently, the last amazing speaker said that the way we are addressing the link between trauma and addiction is still very poor, right? And this is completely true. So we ask ourselves, what do we think about trauma and addiction? And by we, I mean the workforce, the community, the patients, our clients. What do we think? Because if we do not know what we think, we cannot make a diagnosis and answer why the interventions are so poor around the world. So we launched a global campaign in May and asked the workforce, okay, so what do you think? What are the myths you think, you hear, you have between the link of trauma and addiction? And we received 52 myths across 13 countries across the globe. And you will see we received from all around the world. And I want to share some of the myths we received with you. This is from the workforce, from communities, from families. This came from the US. Listen to this. Said, trauma only comes from severe, life-altering or massive experiences. So this means that if you are undergoing neglect or emotional abuse, you cannot develop trauma. Another one we received from Argentina. Trauma is something that only happens in childhood and causes consequences later in life. So if actually we believe in this myth, it means that if you're adult, you cannot develop trauma, and children only have consequences later in life. Let's see another one. This came from Denmark. Trauma can be treated without first quitting the addiction. And this comes to the heart of treatment and recovery efforts. Although overwhelming evidence is saying we need to treat trauma and addiction at the same time when possible, because it gives the best outcomes, we're still having this kind of myths. This one came from Kenya. Addiction and trauma are not connected at all. There are no relationship between them both. So if we actually believe in this myth, what happens? We cannot make any prevention efforts that links trauma and addiction. And this last one came from Pakistan, one of my personal favorites. It's mental trauma is not as serious as a physical injury. Well, what can I say? Trauma is a physical injury. So if we believe in this, we still believe that trauma is something abstract over there that we cannot touch, that we cannot see. Actually, we can't see trauma, and we see it on MRI scans. Trauma changes our brain in structure and in functionality, and it changes our body. So these are 5 of the myths I chose for you to see how big the problem is. So what are the risks of this myth perpetuation? So one of the most complex is silence, and silence, it's one of the best allies of long-term trauma. And if a person thinks that it's an adult, but is undergoing emotional abuse, it's not life-threatening. So if she thinks or he thinks it cannot be trauma, it will stay silent. So probably making the stakes high for long-term trauma. We still see a disconnection. Number 2, the disconnection from trauma and substance use disorders. We need to start addressing that trauma and substance use is extremely linked, especially as the previous speaker said, we are talking about self-medication a lot, emotional self-medication. So if we cannot be clear and we don't believe in this, we cannot make prevention interventions about this. And the third part, the neurobiological unawareness. I cannot state this as much. Trauma changes the brain and the body. And remember what changes everything for a treatment and recovery. What was it? Was when neuroscience showed that actually addiction changes the brain. That changes everything for treatment and recovery efforts. So let's think the same, because we have the evidence base that trauma actually changes the brain as well as addiction. So the question is, okay, so we know this, so what can we do about it? Well, we can address it, but how? This is what we learned. We need to address it in a way that is relatable, the way is easy. People have no time, so it should be easy, and it should be evidence-based. So we took, with the team, we took these 3 principles and we developed a toolkit that is called From Myth to Action. That is a toolkit for the workforce, for families, for communities, and even for policymakers. So what we did was taking 10 of the 52 myths we received, and we dedicate 1 page per myth. What we did is take the myth and make it a question, so to not reinforce the myth. So as you can see on screen, myth number 1 asks, are addiction and trauma truly unrelated, or does trauma play a significant role? Well, we go straight to the facts. Up to 95% of people with addiction have experienced trauma. And we know that trauma is one of the strongest predictors. And then we use neuroscience in a short paragraph to explain the link. And at the end, we always give tips. So the first one would be, assume trauma is always present, even if it hasn't been disclosed. Another one is, can children really experience trauma at a very young age? Yes, a categorical yes. We explain in this toolkit in 1 page, in a very easy and relatable way, how actually it alters the brain architecture of the brain of the child and as an adult. And then we give tips. So take a look at the number 1. It says, we need to name and validate their feelings. We need to create safe and predictable routines. We need to be there for the child when in trauma. As you see, this can be used for anyone: community, treatment centers, family members, individuals. But we said, okay, we need to go 1 step further, because we are taking the myth, we are receiving from people, we are giving the answer, but we want to go from awareness to action. So what we did was, in the same toolkit, we created a guided exercise to break the cycle. So you will find different pages depending on what you are and what you want. You can be an individual, a family member, a policymaker. The one I'm showing you is for teams and communities around the world. So what we did was making very easy and short questions to create answers in teams. So we don't give the answers, they're just ways, we're just guiding ways into create new solutions to problems you find in your own treatments or communities. So what we did was we said, okay, we have all this, let's put it in the Word. And we did 3 pilots in Argentina, in South Africa, and in Pakistan. And these are the results. We did this with the workforce. And they all said 100% of myth clarification. 92.9% of them said they had a perspective shift between the link of trauma and addiction. 100% of them said they would recommend this toolkit to others. And as you can see, there's a very high rate of applying what they learn of the toolkit in their work and in their personal life. And actually, they're very likely to reuse the exercise again. So this is a snapshot of the results that we had. And now for you, the good thing is this is available in English and in Spanish. It's free and it's coming very soon. Thank you.
Thank you, Rocio, for highlighting the myths and trauma that are there. I know, and then also the toolkit, which is, I mean, I'm a little bit biased maybe, but I do think it's a very great toolkit, and thank you for highlighting it here. And yes, it will be coming very soon. And I think everyone here might then also receive a link afterwards once it's been released. So thank you so much for highlighting it. With that said, I would like quickly move on to the next speaker so we have enough time. I would like to introduce our next speaker, Agnes Chen. She is a registered nurse and social justice innovator and proud first-generation Canadian dedicated to anti-oppressive, trauma-informed approaches to health and well-being. The list goes on, but I don't want to take much time of your presentation, so the floor is yours.
Thank you so much, and thank you to everyone who's already presented and everyone here listening. I will try to speak as slowly as I can to get through all our slides. My name is Agnes Chen, as mentioned. My pronouns are she, her. I'm a registered nurse, a trauma-informed consultant, and the founder and executive director at Starlings Community. We are a not-for-profit whose mission is to strengthen the ecosystem, that community of support around young people who are growing up with what we call the stress and stigma of apparent substance use through peer leadership, youth mentorship, and caregiver and professional capacity building. My colleague Sandra was going to be presenting today, but she can't, but I do have a short clip of her speaking that I will share throughout this presentation. So why are we talking about this? Trauma is a huge focus of conversation. In the 18 years that I've been a registered nurse, trauma-informed care has been on the rise. We continue to talk about it. How does it relate to the context of the work that I do? So we know in Canada, and this is a similar global statistic, but more focused from a Canadian context, it's about 1 in 5 young people are growing up with the stress and stigma of apparent substance use. We know new literature and data came out this year from the United States highlighting that it's about 1 in 4 young people are growing up with parental substance use challenges. I will add in, as we are in a toxic drug supply, there is little data that discusses how many young people are bereaved to a toxic drug supply, but there is literature outside of the US, again, highlighting that more than 300,000 youth have lost a parent to substance use challenges from 2011 to 2021, and that came out last year as well. And so 1 in 5 young people are growing up with the stress and stigma of apparent substance use. When we look at the data and the literature, it highlights that young people are at double to triple the risk for poor mental health, substance use challenges, and suicide. And so I always like to pause at this moment to think this is huge, right? If we think 1 in 4 to 1 in 5, double to triple the risk, data highlights young people who grew up in a home with parental substance use challenges, particularly if both parents have mental health and substance use challenges, they're at least 50% risk for having substance use challenges themselves. And so why does this risk exist? And so related to this conversation, when we dive through the literature and unpack it and go down the rabbit hole that we do to really start to understand and ask the questions, why does this risk exist? And these questions are so important because that's how we're going to find our solutions. And so when we look at why does this risk exist, we can see it points a lot to trauma within the home, right? The enduring effects of parental alcohol use on child well-being, association between maternal use and internalizing and externalizing behaviors in young people, the impact of parental substance use on family-related problems and school outcomes. And so when we look, a lot of the literature points to that home environment. And so that brings us to this conversation on trauma, of course. Right? The literature highlights again, particularly if you look at adverse childhood experience literature, it does talk about increased risk for intimate partner violence within the home, parental criminalization. We've heard lots about already, criminalization of drug use, which I'll touch on, emotional, physical neglect, right, which can contribute to this risk. What we also know, though, is that substance use challenges are rooted in the social determinants of health, such as chronic poverty, systemic racism, and unaddressed trauma. So we have to consider, well, how does unaddressed traumas impact a parent's emotions, behaviors, stress management, and their capacity for nurturing parenting practices? Related to current events, again, the toxic drug supply. We know from a Canadian context, the average age of death from the toxic drug supplies is 30 to 49, and the average age of a first-time parent in Canada is 31. We know parents are dying from the toxic drug supply. How are young people being supported? In a survey we did in 2021, where we had 207 individuals respond, who grew up with parental substance use challenges, with 70% of respondents being under the age of 25, 72% identified as being in a caregiving role for a parent who has substance use challenges. How are we ensuring young people have respite, have access to community? Again, we know that more than 300,000 young people have lost a parent to a toxic drug supply. We know many young people are finding a parent who has died or who has withdrawn, who has overdosed, who has taken a toxic drug supply. They are first responders in these crises. And we know that concurrent mental health challenges exist, of course, with parents who have substance use challenges, as has already been highlighted. And so do these parents have access to support and community and resources to heal without fear or stigma and shame? And I highlight all of that because the big question we always ask at these conversations is, can parents with substance use challenges reach out for help and receive support without fear or shame? And can their children? When we look at data today, again, from a Canadian context, and I encourage everybody from your local and regional context to have a look. If a young person or if a parent reaches out for help and they are a parent, there is increased risk of criminalization and family separation. We know the primary caregiver risk factor in Canada for involvement in child protection services is substance use and mental health challenges, which intersects with poverty. We know that 50% of individuals, I'll correct my statistic here, up to 90% of individuals in Canada's federal prisons are there on substance use related charges. And there is data that shows that 50% of males are parents and at least 37% of women are mothers. And so can their children reach out for help? When we think of that statistics, 1 in 4 to 1 in 5 young people are growing up with parental substance use challenges. They're at double to triple the risk of adverse mental health outcomes, including substance use challenges and suicide. Can they seek out support without fear or shame? And as this conversation alludes to, many cannot. And so I've heard stigma from the last two presenters be discussed, right? How does stigma impact individuals? We know stigma is an issue. If you Google stigma, there's about 1 million search results that come up. There's similar amounts of trainings that we have. Our organization, myself included, we do lots of trainings on stigma reduction. How do we reduce it? We know it's a public health issue. We know it's an important social determinant of health. But what does this mean for young people? And so again, the focus of individuals who utilize our resources, supports, and programming are youth age 16 to 28, and then youth 6 to 12 through our caregiver supports. And when we ask individuals, how does stigma impact them? This is what they told us. I didn't reach out for help as a youth because alternatives to living with my parents were much worse. I was too scared to be taken away. Seeing them, their parents, deal with the stigma makes me feel even more guilty and angry for wanting to be away from it all. Stigma has made it difficult for my family members due to their shame to discuss this. It's hard to reach out when there's so much shame. Kids know drugs are bad and they shouldn't be doing it. So why would they talk to someone about it? Of course, individuals who access our programming and resources often do come with their own substance use challenges. But when they see how society, community, family has treated their parent, they're going to internalize that. And that's going to become a part of their identity and a part of their identity that they want to hide. Listen to those introductions. I'll just quickly, this is a quick 30-second video of our youth lead, Cassandra, who did lose a parent to the toxic drug supply, sharing, what did young people say? How do they internalize it? What meaning do they make of this stigma? Listen to those interactions. So when we ask, what meaning do youth make of all these assumptions and behaviors? This is what we hear. Not just that stigma exists, but that it shapes how young people see themselves, their families, and their futures. Youth are navigating systems that often see them through the lens of their parents' substance use. It's not just a health issue, it becomes a character judgment.
And when no one challenges those assumptions, it's easy for youth to start believing them too. So the truth is that these labels here, addicts, kid, broken, no point trying, there aren't reflections of who we are, but they become barriers to how we show up, how we ask for help, and how we trust others to see us beyond the stigma. This is where the opportunity comes in, to reflect on how these patterns show up in your work, your conversations, and the spaces you hold for youth. So with that, I'll pass.
So as Cassandra noted, we define stigma a little bit differently. We often hear the definition of stigma being assumptions, behaviors, judgments that lead to discrimination. That focuses individuals causing the harm. And for many of us, and I'm sure in many of our circles, we have heard people say, I don't stigmatize, I don't discriminate. And so we flip that definition on its head a little bit, and we center the voices and experiences of people who are impacted by stigma. And so we say stigma, this is based off of the work of Irving Goffman. Stigma is a process by which the reaction of others spoils a person's relationship to their family, their community, and themselves. And so stigma is traumatic, and that trauma lives in the body. And I know we heard a brilliant presentation on how stigma affects emotions, behaviors, capacity to listen and learn, capacity to engage in trauma healing spaces and resources, capacity to even understand that what you've experienced is traumatic because of how the world has treated or how the world has had resources and supports available or not available. And so what does that mean for us in our context? Trauma healing, we look at it from the systemic healing. We want to ensure we can rebuild the relationship young people have first and foremost to themselves. And we do that through a youth peer leadership program, understanding your rights, but in a way that allows young people to know they can experience their rights and they can lead these conversations. And so this is just examples of some of that programming. You know, what do you want people to know about your experiences of growing up with parental substance use challenges? Give help, not hate. Families belong together. I'm good enough. So we create resources, all peer-led, all evidence-informed, that really centers the experiences of young people and gives them back their autonomy and agency to heal from what they've experienced. And so we use advocacy and peer leadership as a source of healing. You can find all of these on our website. We have lots of different information. This was at an event we hosted this past spring, right? Addiction needs love, not blame. Every family separation is a policy failure. We deserve a future that doesn't include fighting to be seen. Bad families don't exist, bad labels do. And these are all from individuals with lived experience. And so our work centers on how do we rebuild these relationships and ensure that the community and the family and society has the resources and supports to make sure that we are not re-traumatizing, and that most importantly, young people and their parents can access resources and supports without fear or shame. There's QR codes there. There's lots more I know I can get into, but recognizing everybody's time and the depth of this conversation, please feel free to reach out, have a look at our website, and email me if you have any questions, agneschen@starlings.ca. And thank you, Dianova, for this, and Gisela for this opportunity again.
Thank you so much. Thank you so much. See you, Agnes. And of course, Cassandra as well for your wonderful and very moving presentation. So always is amazing. You have reminded us that stigma is not only a social issue, it is trauma in itself, one that affects generations and shapes identity. I want to sincerely congratulate you for your extraordinary work and for bringing lived experience and peer-to-peer practice into this space, a practice that are helping to redefine what trauma-informed care truly means, especially from a child and family rights perspective, like, for example, the material you show us, which is amazing. I highly recommend your materials and resources. We will make sure to share more information about Starling's work in the chat. So thank you very much again. And now we will continue our journey to Asia to explore another essential perspective. It's my honor to introduce Asia Sharaf from the Greenfield Hospital of Psychiatry in Pakistan, who will speak on healing with evidence, trauma-informed gender-sensitive care. Asia is a devoted professional with over 18 years of expertise in drug addiction treatment, rehabilitation, prevention, and recovery. And she is a global trainer and pioneered the establishment of the first recovery club in Islamabad, providing a safe space for persons in recovery. Welcome, Asia, and the floor is yours.
Thank you very much. Thank you very much. Good day, ladies and gentlemen. It's pleasure to be among you all. And I am successful in running my presentation. Thank you, Grisila and Cressida. You were there to help. So it is pleasure to be among you all. And I would like to say thank you to the Dianova International and World Federation Against Drugs for organizing this very important webinar and for giving me the opportunity to contribute as a speaker. So as you mentioned, I'll be talking about healing with evidence, trauma-informed gender-sensitive care at Greenfield Hospital of Psychiatry, Pakistan. Okay. I'm not able to move it like
You can go to the screen and then click on it, where the presentation is, with your mouse.
So yeah, it is there.
And
Oh
then-
yes. Okay. From here?
Mhm.
Yes, thank you, Christina. So Pakistan is a beautiful country with over 255 million people, and its geographical location make it as a transit corridor and consumer for illicit Afghan drug. So as per the UNODC survey conducted in 2013, there were 6.7 million illicit drug users. Unfortunately, we do not have any updated survey. So in that survey, the female drug abuse was around 1.5 million. And that survey, female drug abuse is actually underreported, under-researched, and understudied. And clearly, that data underrepresents today's reality. Currently, in ice or crystal methamphetamine, it is like a huge pandemic in my country, and especially the use of ice among young girls and women is widespread, particularly in the educational institutions. And if we talk about the treatment capacity, there are only 96 drug treatment and rehabilitation centers, as mentioned in UNODC survey. Only 30,000 people in a year could get treatment, and the most of the treatment is male-oriented. There is no specific female-specific centers. Some of the treatment centers are available, but they provide some sort of the mixed gender treatment that truly does not understand or fulfill the needs of the women. So trauma and addiction among women, how as we know that trauma and substance use, they are deeply intertwined. One often fuels another. So many women in Pakistan who use substance abuse, they have experienced trauma from gender-based violence, poverty, sexual abuse, social stigma, or loss. And substance use become their coping mechanism to numb their anxiety, shame, and pain. And over the time, substance use itself creates new layers of the trauma through violence, social exclusion, and exploitation. So this creates a cycle of trauma and addiction where pain drives use, and use drives more, deepens the pain. So this is like the vicious cycle. So there are a lot of myths related to the trauma in Pakistan. I'll just touch the very few, which are very important with reference to the socio-cultural context. The most important one is good women stay silent about their pain. That is a cultural norm that often expect women to suppress their pain, and good women do not bring shame to the family. And if a woman experiences abuse, she must have done something wrong. Victim blaming is widespread, like so shifting the responsibility from the perpetrator to the survivor. So, and emotional trauma is not real. Women are just too sensitive, so overly just dismissing or trivializing the emotional and psychological injuries by saying this, oh, forget about it. It happens to everyone, and blocking them from getting help. Marriage or motherhood will heal trauma. Many believes that family life can fix trauma, while unaddressed wounds, they affect her mental health as well as the relationship. And therapy is unnecessary. Faith and patience alone will heal.
Faith is a source of strength, but definitely trauma treatment requires appropriately trauma-informed care. These were the few myths which are common. And as Roshio mentioned, we contributed in her project, in Safi's project, where the myths were scientifically debunked. We shed many myths, and successfully they were scientifically debunked, and it is a great initiative and very helpful for the country. And why the women they're reluctant to seek help? They fear exploitation by quacks. They fear social stigma. Family, because of the family reputation, cultural constraints, fear of losing children, marital risks, and most importantly, there is lack of services because they lack trauma-informed care services. There is dearth of expertise, so they're reluctant to seek help. So when women are entered in the mixed gender treatment, they often face re-traumatization due to lack of safety and gender-sensitive care. Without addressing trauma, recovery remains incomplete, and relapse risk increases, and healing remains superficial. So trauma-informed care is not optional. It is essential for breaking the cycle of addiction. What we are doing at Greenfield Hospital of Psychiatry, it's a facility that provides state-of-art treatment to the women who are suffering from substance use and mental health disorder. And how we do that, we literally follow the 6 principles of trauma-informed care approach, that is safety and gender-based violence, the trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, cultural, historical, and gender issues. And I'll go through like how we are actually applying those principles in our daily care. Most important, the treatment environment matters. Physical environment and the psychological environment. It should be very safe for the women. So in the environment, the treatment is approached from the context of women's life. It is an environment that fosters healing and dignity, and the staff is available. We listen to our patients and we keep them informed of every step, like what is happening in the treatment. Staff keep promises, they are helpful, and we try to address complaints immediately, and staff take extra mile to sort out their problems and to facilitate them. And we try our best to create a culture of respect and positivity to restore the dignity and hope. And the Recovery Lounge, that is the most cherished corner of Greenfield Hospital of Psychiatry. It is a peer support corner, like where the women over a cup of tea or coffee, they talk to each other, they share their experiences, and they talk about their different issues, and they participate in different activities like art, painting, mindfulness exercises, and they just enjoy their time over there. And we have understand that informed, compassionate families, they're important pillar of trauma-informed care. So we invest a lot on the psychoeducation of the family, conducting support groups, family psychotherapies, family counseling, and marriage counseling. We focus a lot on the psychoeducation of the family members. And we keep training and updating the staff with the new knowledge about the trauma. And there is a very intensive supervision is available to deal with the vicarious trauma. And we all understand what vicarious trauma is. And we keep in view the cultural competence, like we really appreciate the background of the women, their values, the cultural experience, and their lived experience as well. So one example of cultural experiences, like most of the treatment providers or the staff member, they're women. So they ensure that they can easily build the trust, they can develop like they get the care what they need, and they can trust. And we focus on the post-traumatic growth because healing goes beyond the treatment and recovery. So we focus on transformation, where they can go beyond the treatment and they can rise wiser and more resilient. And we do a lot of advocacy.
Just one more minute, Asya.
Yes,
Sorry.
I'm last slide. So we do a lot of advocacy at national and global level because the recovery goes beyond the walls of the greenfield. It is actually into the communities, into the system, and into the family. So we really focus on building trauma-informed society, a society that listens before it labels and supports before it judges. And that is the society we must build. I am going to conclude my presentation with this lines that healing requires both science and sensitivity, integrating evidence-based interventions with compassion, cultural understanding, and respect women's dignity and rights. Thank you very much.
Thank you, Azia, for the great presentation and also highlighting this important aspect of women in recovery, or women with addiction, and the need for them to have sensitized treatment, and also the need for the trauma informed care that is required. But also, of course, it's said to have it culturally adjusted and sensitized. I think those are very two important points that often are overlooked. And I think earlier in the graphs that Angela shared is that also in Asia, unfortunately, the difference between male having access to treatment and females having access to treatment, there's a huge gap. So thank you for all your work to trying to close that gap locally as well as internationally in advocacy. So with that, I would like to introduce our next speaker, Evelina Mincheva. Sorry if I mispronounce your last name. She's a social worker with extensive experience in the field of addictions and a founder of Nesafisima Foundation, whose mission is to support women affected by addiction through a comprehensive program of treatment, rehabilitation, and social inclusion. The floor is yours.
Hello, everyone. Thank you for inviting me, Dianova. My name is Evelina, and I'm a social worker specializing in addiction. Alongside my practice, I'm training in psychodrama and the therapeutic spiral model, which woke up my interest in trauma and especially trauma related to addictions. Today, I will talk about trauma and recovery among women in Bulgaria. Sorry, it doesn't let me. Okay, fine. This is topic very interesting, a topic at the intersection of social vulnerability, mental health, and gender inequality. I will focus now on how factors like poverty, violence, and stigma shape women's access to care and influence recovery services. I have to say Bulgaria is a country in Eastern Europe, and it's about 6 million people, so we're a very small country. And many women in our communities grow up with multiple traumas. They experience domestic violence, sexual exploitation, childhood trauma, and very often live in poverty. These overlapping challenges require careful and gender-sensitive support, which is unavailable at the moment in our country. Women with substance use issues often face a double burden: gender-based violence from one side and both institutional and social stigma. I would say medical stigma as well, especially in pregnant women with addictions. In Bulgaria, most recovery services are designed for men, and gender-sensitive care is very limited. Trauma-informed approaches are largely absent from addiction treatment. I will show you the latest data. You can see the data, and it's very worrying. This is the Q2, April to June, the registered cases of acute intoxication related to psychoactive substance use. And this is our national source of data. So you can see the girls under 15. So once they're high in number, and this is very disturbing, and this early substance use among girls reflects the trauma they face. And it's crazy because we recently did a local in our municipality. We did a research among the students 14 to 19 years old, and the number of the girls is huge. It's like double the boys. So we got 150 girls tried for first time alcohol at 12 years old, and we got 80 boys tried at the same age. So it's very disturbing. These numbers reveal risks our system is not addressing, and the real figures are likely higher, not likely, they are higher. These are only recorded cases. Right. In Bulgaria, free recovery opportunities are extremely limited. We got only one psychiatric hospital that offers few places for people to recover, and there is no specialized women ward with bed, especially for women. We have no programs that allow women to enter treatment with their children. Therapy is mainly behavior focused and aiming to reduce substance use, but often misses underlying causes, including trauma and social disadvantages. Trauma-informed care is still in early stages. I was ashamed to say it's not existing. So that's why I said it's in early stages. So treatment teams need more training and more support. Women with children or complex trauma often lack support, showing gaps in services and the need for integrated trauma-informed and family-focused programs. In Bulgaria, we have no programs for pregnant women. Specialized support for their medical, psychological, and social needs is non-existent. Many mothers face stigma, fear of losing custody, or lack access to care, which prevents early intervention and affects both their health and their children's well-being. In this slide, I would like to share with you two cases from my practice that illustrates these gaps. I worked as a social worker in one of the therapeutic communities, a private led by NGO. So these are only two of the many cases I want to point to make clear. So PP, 36, grew up in a family affected by substance use and discovered her mother's body after she died by suicide. As a young adult, she was in an abusive relationship and became a victim of sexual exploitation, forced to have 2 abortions. Even after several treatment attempts, her trauma and experiences of violence were never addressed. Care focused only on her addiction and to maintain her drug-free. NN, 26, she experienced physical violence. She was sexually abused as a child and began drinking at 14. Later, she started experiencing any drugs. She started trying any drugs that she can afford. She was in a relationship with a much older partner. The male was on substitution treatment, and she became a mother at 24. So during her treatment, she saw her boy only 3 times. Once for 2 hours after the first 3 months, one for 12 hours on her 6 months, and one for 24 hours when she finished her 9 months in the recovery. And it was insane. So she left.
Sorry, 1 minute left.
Yeah, okay, I'm almost finished. And these are the facts that led to think what we can do, what can be done to improve this situation. In February, we established the foundation independent to focus on woman-centered trauma-informed recovery. Since then, we have taken steps to raise awareness, build capacity, and advocate for gender-sensitive programs in Bulgaria. Thanks to a space provided free by our municipality of Gabrovo, where I live, we opened the advisory center. This is one of a kind in Bulgaria, the first one, to offer woman-centered services. The center also addresses intersectional needs and provides safe, supportive environment for women. We have built strong connection with local institutions, medical specialists, NGOs, and community partners, creating a stronger support network for women in recovery. We really wanna our goals are to integrate trauma-informed care and gender equality principles into addiction treatment in Bulgaria, to develop programs specifically for women, including pregnant women and mothers, to provide treatment options that allow mothers to stay with their children during recovery, to promote right-based, inclusive care that responds to diverse needs. In conclusion, women's trauma histories, combined with systemic and social barriers, demand tailored, gender-sensitive responses. By integrating trauma-informed care, creating women-focused programs, and allowing mothers to recover without separation from their children, we can build a system that truly responds to women's lived experience, and this is very important. And the work is starting now. Thank you very much for the opportunity to share our situation in Bulgaria here with you. And thank you to Dianova for the opportunity to share with you. Thank you.
Thank you. Thank you, Evelina. Your organization, Nezavisima Independent, is pioneer in this conversation in Bulgaria, which is very brave. You're doing a tremendous amount of work, so congratulations. You're putting trauma and gender perspective at the forefront of addiction recovery at a national level. So we wish you a very fruitful journey ahead in this mission. Thank you very much again for joining us today and share all this. And now it's my pleasure to introduce our next speakers, and I will do so in Spanish for a translator. Es un verdadero placer presentar a Paula Lozano Garbaccio, quien compartirá su presentación titulada El consumo como anestesia emocional, comprendiendo la conexión entre el trauma complejo y la adicción. Paula es psicóloga clínica, terapeuta DBT y EMDR acreditada y doctoranda en la Universidad de Girona, donde desarrolló una investigación centrada en trauma complejo. Combina su práctica clínica en Barcelona con labor investigadora para construir puentes entre la ciencia y la terapia para mejorar los resultados en el tratamiento del trauma. Así que te paso la palabra, Paula, y bienvenida.
Hola, buenas tardes a todos. Gracias, Gisela, por tu presentación y os voy a compartir la mía. Espero que la podáis ver.
Perfecto.
¿Sí? Bueno, pues es un placer estar aquí con todos vosotros. Espero que me escuchéis bien porque justo han decidido ponerse de obras en el piso de arriba. Y bueno, como os decía Gisela, yo os voy a hablar de la función del consumo como anestesia cuando intersecciona el trauma complejo y las adicciones. Así que antes de nada vamos a hablar de qué es el trauma complejo. El trauma complejo o el trastorno de estrés postraumático complejo es una categoría diagnóstica recientemente incorporada en la última edición de la CIE y aquí podemos ver algunos de los síntomas que presenta este diagnóstico. Tendríamos los que forman parte del TEP simple, ¿no? Del trastorno de estrés postraumático que todos conocemos, como sería la reexperimentación, la evitación y la hipervigilancia. Y por otro lado, y como añadido al trauma complejo, tendríamos la desregulación emocional, donde las víctimas, ¿no? refieren que viven, ¿no? en esta montaña rusa emocional. También presentarían perturbaciones en su autoimagen y dificultades a la hora de vincular, especialmente dificultades para confiar o para mantener vínculos. Aquí os pongo este paper, el cual creo que es importante, fue publicado en la revista The Lancet en 2022 y donde nos expone que la prevalencia general del trauma complejo iría del 1 al 8%, pero que en centros de salud mental llegaría hasta el 50% de los usuarios y pacientes que solemos atender. El trauma complejo, como bien decían antes mis compañeras, se desarrolla en situaciones donde hay abusos, negligencia, en especial en la infancia, pero se puede desarrollar en cualquier edad. Y ya como último dato del trauma complejo, que creo que es muy relevante, y es que estamos viendo a nivel científico que muchas de las presentaciones que creíamos que eran un trauma simple, a día de hoy sabemos que hasta el 66% serían en realidad un trauma complejo. ¿Y esto de qué manera intersecciona con las adicciones? Pues realmente de una manera bastante elevada. A día de hoy también sabemos que hasta el 75 al 85% de las personas que sufren un trastorno por uso de sustancias, a la vez, de manera comórbida, presentarían un trastorno de estrés postraumático complejo. Y vamos a intentar entender de qué manera las personas, ¿no?, que han sufrido, que presentan un trauma complejo, pueden caer en conductas adictivas. El cuerpo traumatizado vive en esta hiperactivación constante y está atrapado entre el pánico y el miedo y la desconexión. Y sabemos que al final esto queda en el cuerpo, en un sistema de alerta hiperactivado. Desde este prisma podemos intentar entender cómo el consumo puede ser un intento desesperado para recuperar la sensación de control. Y ahora veremos algunas de las funciones que se han descrito en la literatura. Una de las primeras sería silenciar la hiperactivación, ¿no? Quien vive traumatizado tiene un sistema nervioso que siempre está hiperactivado. Y desde aquí nacería un poco también, ¿no?, la hipótesis de la automedicación, que está ya es antigua, ¿no?, y se ha hablado mucho de ella, como el consumo, sobre todo de sustancias depresoras, ayudaría a calmar el sistema nervioso, a dar un poco de tregua. Como también os describí anteriormente, uno de los síntomas principales del trauma complejo es la desregulación emocional, ¿no? Quien lo padece vive en esta montaña rusa. Y de nuevo, el consumo de sustancias nos podría ayudar a regular de algún modo, ¿no?, esta desregulación. También a controlar la reexperimentación, ¿no?, la reactivación traumática de estos recuerdos. Y de nuevo la sustancia podría ayudar a generar una barrera entre esta reexperimentación o estos flashbacks y poder encontrar un poco de calma. Y por último, hablar de la disociación. Y es que sabemos que la disociación es un proceso que va directamente unido con todo lo que tiene que ver con el trauma. Y esta se caracteriza, ¿no?, por una alteración en la percepción tanto de uno mismo, del tiempo, de los demás, y resulta de una fragmentación en la experiencia. Y la disociación, como sabemos, ¿no?, va de un continuo donde hay la absorción, ¿no?, que a todos nos pasa a veces, que nos podemos desconectar, hacia el otro extremo donde estarían los trastornos disociativos. Los trastornos disociativos se ha visto que tienen también una relación importante con los trastornos de uso de sustancias. Como veis en esta investigación se encontró que hasta un 26% de ellos, de personas que consumen, también tendrían un trastorno disociativo y que este sucedió, ¿no?, en la mayoría de las ocasiones ya estaba presente antes. Y aquí os quería traer algunos testimonios, ¿no?, uno de una paciente y otro de un grupo terapéutico, y os los voy a leer literalmente y con esto ya acabaré. Aquí dice una persona: con el alcohol llenaba mis sentimientos de vacío, soledad y el miedo. Me ayudaba a sentirme más desinhibida y más vista. Y me ayudaba, ¿no?, a gestionar estas emociones desagradables. También un grupo de mujeres en una comunidad terapéutica decía, ¿no?, que consumir les ayudaba a evadirse de los recuerdos, que así no venían imágenes, ¿no?, que cuando consumían los recuerdos no volvían y que sin consumir pues era más difícil, ¿no?, vivir. Y por último, algunas pinceladas, ¿no?, de cara a la intervención. Os animo siempre a evaluar el trauma y la disociación. Tenemos 2 cuestionarios que son los más validados, el ITQ para trauma y la DES para síntomas disociativos. Tenemos que entender la contradicción que siempre estará presente, ¿no?, en estos pacientes, dada la disociación, que un día pueden querer dejar de consumir y al otro día consumir, ¿no? Y esto forma parte justamente de los síntomas de trauma. Entender la función, ¿no?, del consumo, en qué les ayudó a empezar a consumir. Siempre con enfoques compasivos. A día de hoy sabemos que la terapia centrada en la compasión es un abordaje que está resultando ¿no?, tener mucha evidencia para el trauma. Priorizar siempre la estabilización, ¿no? Siempre hablamos del abordaje fásico en trauma y lo primero es estabilizar. Y luego, en algún momento, siempre hay que tratar de integrar las memorias traumáticas con también terapias basadas en evidencia para el trauma. Y hasta aquí mi presentación. Muchas gracias a todos por escucharme y os dejo mi contacto para cualquier cuestión. Gracias.
Thank you so much, Paula, for this wonderful presentation going and diving into technicalities and also of severe and the complex stages of trauma and how that actually works. Like what Rocio earlier mentioned, it alters the brain, and you kind of perfectly explained and what kind of symptoms it provides, and also the need to integrate it and giving some examples of what kind of tests to do. So thank you for that. It will be very helpful for everyone here, I think, as well. So we are a bit closer to the closing time than we thought we would be after all the presentations, but this kind of shows how great the presentations were so far. I think they were very informative, and we didn't want to cut them too short either. So we have a little time left for the Q&A. We have 2 open questions, and others who do have questions still feel free to post them, and we hopefully can fit them all right in. But I'll just start with the first questions asked. One question is directly directed to Rocio, so I'll just take that one first. It's more of a combined question. So one of them is, how can we collaborate with other entities around the world to implement the toolkit you presented? And how can we, in general, collaborate with the TSAFI task force from different parts of the world?
Thank you for the interest. Of course, I mean, if the toolkit will be available very short. So what you could do is apply it in your work, with your team or with your community if you want. And you can also, if you want, you can follow SAFE for new events and anything new, any workshops we can be doing in the near future. So those are the ways you can collaborate. And of course, you can, I mean, I will write my email here, so you can, if you have any questions, any new ways to collaborate, of course, you can always text me.
Wonderful. Thank you, Rocio. The next question is more for the whole panel, which is from Aroich. Which techniques can we use to deal with underlying depression with substance use?
I can answer.
Yeah.
Yeah. Thank you very much for asking this very important question, because it shows the link between drug addiction and underlying or co-occurring mental health disorders, the link which is often missed in the treatment. So if there is what I have learned in my clinical experience is that if there is like some clear indication of the depression, which is possible to evaluate after 1 month of the detoxification and when the drug use is not is discontinued, because a lot of the drugs, they create depressive symptoms during the withdrawal stage. So once the drug is over and the patient is detoxified, the most of the depressive symptoms, they settle down. But if the symptoms persist after 1 month and they meet the full criteria of depression, And then the first step is like to go for the pharmacological treatment, and next to do the psychological work. Like that should be together. And in that psychological work, the evidence-based therapies to treat the depression is like CBT, and definitely cognitive restructuring and daily activities scheduling, and definitely along with the pharmacological interventions if the depression is clearly diagnosed. I hope it helps.
Thank you, Azia. Any of the other panelists who would like to add? Paula or Evelina or Rocio?
I was writing the information that was requested. I'm sorry.
No problem. All right. Thank you, Azia, for that great answer. I think we have time for one more question. So this is also for the whole panel. Just one second. So bridging knowledge and action, we often talk about the importance of trauma-informed care, but implementation can be complex. What do you see as the biggest barriers and the most promising opportunities to turn this concept into practice?
So what I can say, I can tackle first if you want. So yes, it seems to be like a very abstract thing, but actually it's not when we think about what we can actually do in action. So if we understand, as we talked earlier, that trauma actually alters the brain and the body and alters, as Paula said, and it puts you in hypervigilance, it means that your whole brain is altered all the time. One of the things that is most important, and we don't seem to get it, is to provide safety. It seems such a cliche, but actually it's the most important thing, because that's the only thing it will stabilize a client or a patient. From there, you can start working. If you don't stabilize with security, nothing can be done. And the other thing I want to say is, when we think about trauma-informed, we think about we need to talk with the client or with the patient about the trauma that happened. Well, yes, but maybe not at the first time, because remember that trauma affects the body. So if the body is dysregulated, our prefrontal cortex will not be able to think clearly, so the person won't be able to talk or put the words together. So first, safety, and second, somatic therapies, so working with the body.
Thank you, Rocio.
Sure.
Paula or Evelina, if you would like to add.
Yes, thank you, Rocio, for this point. I would say the same. Listen and don't judge, because we are very, very used to judge from our own experiences, and think and everything shows on our face as professionals. And when it's a lack of training and education in trauma-informed care, especially here in Bulgaria, we focus on CBT in addiction treatment, which work with traumas. But the trauma is not just how to work with the patient or your client. The trauma is how you also behave. So thank you, Rocio, for pointing that out. This is my opinion too. Thank you.
Thank you, Evelina. Alcia or Paula?
I agree with Rocio and Evelina. And what I think is like compassion and understanding. That is very much important, like how compassionate or empathetic you are in dealing with that situation. That I believe that is the very much needed.
Thank you, Alcia. Paula?
Crescida, pues a mí lo que me venía como máxima, ¿no? Es tratar de no dañar, ¿no? a las personas que ya vienen con mucho daño en la mochila, y quizás, ¿no? Para las personas que trabajemos atendiéndolas cuando aún no sabemos de trauma, es empezar a leer, ¿no? Y a informarnos un poco. Y yo aquí les recomendaría a los asistentes El cuerpo lleva la cuenta, de Bessel van der Kolk, que es un libro maravilloso para introducirse un poco en el conocimiento del trauma.
Thank you so much. Okay. Thank you so much, Paula, for that additional note. And also, like I heard, like you have a book title, please write it in the chat and we can share it. I think it will be very valuable to all of us here. It also kind of is I think the tips that were presented is not only how we turn it into practice, but it's very much useful also to empower frontline professionals, which we also are aiming this webinar for. So thank you so much for that. And with that, I would like to first thank all of you on my behalf, of course, and it was an honor to be a co-moderator, and I would like to hand over the word to Gisela for the final closing words. Thank you.
Thank you. Thank you very much, Cressida. And thank you to all remarkable speakers, amazing speakers, for your generosity, courage, and the passion you bring to these fields. Each of your voices has added depth, perspective, and hope, which is very important, hope to this essential conversation. Your work reminds us all that healing from trauma and substance use is not just a clinical process. It's a human journey that requires empathy, evidence, and collective action as well. So on behalf of Dianova International and the World Federation Against Drugs, I want to sincerely thank our audience. Thanks our audience for our presence, thoughtful participation, and commitment to advance trauma-informed and rights-based care. Thank you as well to our technical teams behind the scenes, whose quiet but essential work made everything run smoothly today. And to our interpreter, Patrick, for ensuring that language was not a barrier to connection and understanding. As we close, we invite you all to carry today's insights into your daily work, to keep advocating, to collaborate across disciplines, and to bring trauma-sensitive and human rights into every part of the continuum of care, because each small action can make a difference in someone's life, as we all cover with our intervention today. And please stay connected, explore the resources we will share after the session, and continue this dialogue within your organizations and community. We wish you a wonderful, wonderful day ahead. Thank you very much.
Thank you very much. Thank you.
Thank you.
Thank you, everyone.
You.
Thank you.